Hola amigos, welcome to Crossing Cultures with Christina Luna one more week. This week we have a guest that's a doctor, Dr. Nicole. We're going to talk about breast cancer, her specialization, because it's the month of breast cancer, October, but it's not only October. We should talk about it every month of the year and be aware of it. So let's welcome first Dr. Nicole. How are you?
I'm good. Thanks for having me on the podcast.
Thank you. And I know that you speak Spanish, so hola, ¿cómo estás?
Bien.
Bien,
Tengo
bien.
demasiado trabajo.
A lot of work, right? Yeah, that's great.
Me
But
encanta mi trabajo.
te encanta tu trabajo. Dr. Nicole is an oncologist, hematologist. She'll talk a little bit about it, but this is crossing cultures first. So let's start with a cross-cultural story. I know that you're a little bit of here, a little bit of there, like most Americans, right? So tell
Mhm.
us a little bit about your background, your ancestors, and why is it that you speak Spanish?
So I am mostly Italian. My paternal grandparents were both Italian, but on my mom's side, my maternal grandmother was Italian, and my paternal grandfather was from Spain. He was from Salamanca. So he came to the U.S. in 1929. I think he was like 9 years old. He came over through Ellis Island on a boat, and you know, I have to say I've always felt a little closer to my Italian culture. In my home we just spoke English. When my grandfather came here, they were very adamant about like we're in America, we're going to speak English, and I wish he would have taught me Spanish when I was a kid and when my brain was more flexible. But he ended up passing away when I was in the fifth grade. So, I remember family members visiting from Spain when I was probably 6 or 7, and they brought all their flamenco gear and danced for us, and I got to play with the castanets. But after he died just when I was young enough that I didn't keep a lot of connection with that side of the family. So it was always more my Italian side, and the fact that my father looks exactly like Tony Soprano and may or may not have been in the mob. So I can never get a straight answer on that one, but um, so yeah, so that's kind of my heritage. I did not learn Spanish until I was an adult because I've worked in throughout my. I've been in practice 14 years. I've worked in Allentown, Reading, and Bethlehem, which have large Spanish-speaking populations, and there have been some days when I literally couldn't get my day started because I didn't have interpreter services, especially those days before they had the iPad interpreters. Like you had this crappy blue phone you used, and it was suboptimal. And then actually what I've come to learn as I've learned Spanish over the years and actually been able to use it with my patients is that even like the iPad interpreters, they don't interpret accurately all the time.
Now you know
So
that, right? That you know
yeah.
Spanish.
Well, and you know what? It's hard because people don't pause to allow for them to interpret things. So a patient will talk for like minutes and they have to remember everything that patient said and interpret it into the other language and remember like numbers, complex medical instruction. So I try to be kind and patient because I still use an interpreter sometimes. There are some patients, they mumble or they use too much slang or whatever their dialect or accent is, I struggle. So if I'm nervous about any barrier to communication because of I always say work is not for me to practice my Spanish. If I don't feel like I can understand with accuracy, I get the iPad, but I have caught the interpreters in errors. So, or like I say something weird like myelodysplastic syndrome and I hear the pause and then I can tell them how to say that in Spanish.
Oh my gosh.
So even though like I'm not 100% of the time, I still use interpreters. I feel like it really has like enhanced my communication accuracy with Spanish speaking patients and to make me a more empathetic communicator. Because when anyone has an accent of any type where I know like their first language is not English, I make sure I slow down. I spread my words out. I don't use slang, speak slowly because that's how I like Spanish to be spoken to me. So I feel like it's made me a more kind communicator.
Well, I know that when you were talking with Nicole earlier, preparing for this interview, you were talking to me about how you used some words that were not correct you translated into Spanish, but we can leave that for lost in translation, right?
Yes.
You only spoke English, But you came from two cultures that is about fiestas, about food, about getting together. What of these traditions did both of those cultures did you bring your family bring to your childhood?
I mean, I actually always say we're all very similar, especially Italians, Jews, and Greeks, because it's all about yelling, eating, and guilt.
That's true.
Yeah. So what I remember from childhood is, just the food that my grandmother used to make and my mother. Unfortunately, it didn't stick to me. Like I was always just the school nerd studying, and I never really had much of an interest in learning to cook. So my poor husband did not benefit from my culture because I never really rubbed off on me, but it gave me some excellent memories. And I just remember the huge meals that my grandmother and my mom used to prepare at the holidays and even on regular days. So,
Well,
and of
that's great.
course, mafia culture. So, I have to say, my father he passed exactly like Tony Soprano, and when I watch The Sopranos, I have so many deja vu moments from my life. Like I always joke with my mother and like want her to tell me dad was really in the mafia, right? Because I just remember Italian gentlemen coming to his place of work with like manila envelopes full of cash. I'm like, what's that for, dad? So yeah, Sopranos speaks directly to my soul.
Your son. Okay. Now, what did your father say about those huge envelopes of cash?
There's never real straight answers about it.
Boy, that's suspicious, very suspicious. But
Yeah.
now let's go back to now who you are today and why we're here. We're going to talk about breast cancer, but first we want to know about you. What made you want to become a doctor? Because I know that wasn't your first major, right?
Right. Yeah. So when I was in high school, I took a computer science class and got really into computer programming. I had a really good teacher who I'm friends with to this day, and I yell at for being too good of a teacher. So I thought that's what I wanted to do. I went to Penn State undergrad, and I was a computer engineering major. Like I did an internship in computer. It was like mostly computer programming and just kind of going through the major. It was a real struggle. Like my grades were fine, but it did not come easy to me. In 1996, I was away at my internship. And then right after that, I went out to visit my cousin Chris, who was a huge influence on my life. Chris was a gay man. He actually produced the very first VH1 Fashion Music Awards. So when he came out to me, no one was surprised that Chris was gay. But what I was sad to hear when he told me that was he was also HIV positive. So he eventually ended up moving out to Minnesota, lived in this like awesome gay community out there. Just the people were awesome, so kind and accepting to me. And it was around the time like the mid 90s was a time when there was a lot of drug resistance building up to the drugs we had, and it was right on the precipice of the newer drugs which have changed the game for HIV. Like life expectancy is normal now. Maternal transmission is essentially not a thing. So, it just was like an inspiring time in that disease, and to see how it helped people and changed their lives, and it actually like made a difference because the internship I was in was pulling data off a giant database to see who got telemarketer calls and junk mail. I was working for the AARP, and I would write code to pull that data down from their giant databases. So I was like, this cannot be my purpose in life.
I
And
understand that.
I had that formidable experience right at the time. I realized I probably picked the wrong profession. And, the thing about med school is you don't have to be a pre med major, you just need the prerequisites. You need your calculus, your physics, your inorganic chem, your organic chem. You just need the prerequisites. So I just went back, took all the prerequisites that weren't part of that major, and applied to med school and got in. So if I could give one piece of advice, especially to people who are younger, is do an internship. See if you like the thing you're studying to do, and try to do it early so you don't go beyond a point of no return. Because that was probably the last second I could have changed my major, and it was came at all at the right time.
And what made you want to become an oncologist, hematologist?
Well, my there is a lot of cancer in my family, and my grandfather, who I mentioned, was from Spain. He passed of a glioblastoma, which is an aggressive brain tumor, in I think in 1988, and that was like my first formidable experience with death at a time in your life, like around the age of 10, when you can start to comprehend those things. Um, so, like I kind of had a score to settle. Yeah, it was really, when I was thinking about what I wanted to do, these are all subspecialties of internal medicine. So after med school, you do a residency in general internal medicine, and then you specialize after that, you do a fellowship. And I did have an interest in infectious disease because of my experiences with my cousin. Oncology. So the specialties hematology and oncology, they're linked. So hematology is blood, and within that, there are clotting disorders and bleeding disorders. It's non-cancerous, so like hemophilia. But there's also leukemias and lymphomas, and those are cancers of lymph nodes, cancers of the bone marrow, and blood. Um, and then oncology is more the solid tumor stuff. So breast cancer, colon cancer, lung cancer. Two fields I think are forever linked because it really all started with childhood leukemias. That was the birth of modern oncology. It was like 1947. Sidney Farber of Dana-Farber fame now was a pathologist, and he was just looking at leukemia cells under the microscope. And if you think about it, if you're treating a cancer, you got to know if it's working. And they didn't have CAT scanners back then. They barely, like, they had X-rays, but how do you know if your treatments are working? Well, you can look at leukemia cells under the microscope and watch them go away. So that was the birth of giving chemotherapies like the early nitrogen mustards, the folate antagonists. These were all the very first chemo drugs. So you would give them to patients and then draw their blood and watch the leukemia cells be less and less. And that's how you assessed if it was working. So that's like why these two fields are linked forever. And really, like, oncology boards didn't even exist probably till the 80s. It was all just hematology. And then as the field learned more and more about solid tumors, you kind of had that offshoot of more solid tumor oncology, and it became like two separate categories, basically.
And every oncologist has a specialty, or all cancers go to the one oncologist, let's say.
So there's four main types of oncologists. So there's surgical oncologists, so the people that cut it out. Radiation oncologists, so we use, radiation to treat some cancers. Medical oncologists, which is me. Those are the chemo doctors and now targeted therapies and immunotherapies. And then gynecologic oncologists, who are both surgeons and they give the chemo. It's a category of diseases that need both in that area, and it's really specialized surgeries. So that's kind of why there's this offshoot of gyn-onc. In my field, in medical oncology, what has happened is, with the explosion of research, now we are subspecializing. So my subspecialty is breast cancer. And I was drawn to that because my mother's a breast cancer survivor. That happened in my last year of training. She was treated for breast cancer and she's doing fine. So that gave me an interest. Yeah, so I do mostly breast cancer. And then I also do some hematology, like bleeders, clotters, leukemias, lymphomas. And I also see a little GI. What's really my specialty? It's breast cancer. But it's kind of an informal thing, especially in the community, because, we all have our interests and the things we kind of stay up on the most, and the tumor boards we attend, to be, the expert person in that. So we get some choice in that. My institution kind of lets us decide what we want to focus on, and then the schedulers schedule accordingly.
So you said your mother had breast cancer. How was it for you emotionally, as a woman, as a daughter, as a doctor,
Mhm.
uh, when your mother had breast cancer? How did you take that?
Here's the thing about me. I have learned to put some pretty heavy guardrails on my brain. When I'm in doctor mode, there's very little emotion. Like, the thought is abnormally rational, maybe my defense mechanism a little bit. So when my mom was going through it, like, she was terrified and scared, she's scared and emotional. I kind of just like put that on the shelf. And when we were at doctor's visits, like, it's really hard to think when you're scared. So I knew I had to be like the logical present one. Like, I remember every detail of her case. And it's really funny because all these years later, I'll say, like, remember this, remember that. She's literally blocked it all out. She remembers nothing.
That's human
It's,
protection,
yeah, it's
survival
really
mode, right?
impressive. It's really impressive how much she does not remember. And I remember every bit of every pathology report. So, like, I have the role in my family where I'm like the calm, rational, non-emotional one, and that's a very comfortable place for me to be. But I will say, like, the most enlightening part of the experience, two things. I remember the day they told her she was gonna need chemo, and I watched her mentally exit that room. Like, it was just me and her doctor talking, like, she had checked out. She didn't hear a word. And then the day she was getting her chemo, they were just infusing the nausea meds, like the pre-meds, and she just burst into tears, and I'm like, "Mom, you're not even getting any chemo yet." So, I think it was good for my empathy, and, also her doctor was a total jerk to me. He did not like me there asking questions and treated me like an adversary. And I promised myself I'd never treat a family member that way because, we're all on the same team.
Yeah, wow, that's tough, really tough. But let's
Hmm.
focus on breast cancer. Is it still today? I'm so glad that your mother is okay. So that's great news. Is it? Can you really get cured of breast cancer, or people when they heal is here to cancer, they think, oh, I'm going to die.
The best way to be cured of breast cancer is to get your mammogram every year because breast cancer is highly curable when you catch it at an early stage. So you don't want to wait till you can feel it because if you can feel it, it's big. We want to catch it when it's a couple millimeters and it's small and it hasn't spread to lymph nodes. So most people who get a mammogram are cured. It's not nothing's foolproof, but most people who catch it at an early stage can be cured.
Yeah, okay, that's
And
good
the
to know.
cure is surgery.
Surgery. It really, it's surgery. You have to have surgery no matter what.
Yeah, the cure for breast cancer is surgery. All the things that we do with radiation and chemotherapy and hormone blockade, it's to clean up anything microscopic that might have gotten out from the initial tumor that we can't measure. So we kind of give everybody the treatment to help some. But yeah, like without surgery, there is no cure. So if something has spread outside the breast to bone or liver, at that point, it's not curable. So you want to catch it early and you want to get your mammograms.
Okay, we'll talk about all of that. But also, what are some of the myths and facts? Because, people have all these ideas about breast cancer, right? And can you tell us some that you have heard from colleagues, from patients, from your experiences, from conferences?
Well, I think some people are scared to get mammograms because there is a small amount of radiation exposure. And I think there's this fear that the mammograms are somehow causing breast cancer. The radiation exposure from a mammogram is negligible. You'll probably get more exposure from your phone.
Yeah.
So that's a myth I've heard here and there. A misunderstanding I think that confuses patients. A lot of breast cancers are hormone sensitive. So sometimes when I'm talking about treating a breast cancer, I'll say, it's the hormone pill and they think I'm going to give them hormones and I think like as doctors we're too cavalier sometimes with our language. It's really hormone blocking. So I think I've scared some patients sometimes, like, wait a minute, you told me this was estrogen sensitive. Why are you giving me hormones? I sometimes doctors need to be a little more precise and not create confusion. I think some women blame themselves if they've taken hormone replacement therapy if they get a breast cancer. Like there's different types of hormone replacement, like estrogen progesterone combinations or estrogen alone. A reasonable amount of like hormone replacement, it's okay. The risks are less with estrogen only hormone replacement. If you have a uterus, you can't have estrogen without progesterone because the uterine lining can kind of thicken. So if you have to use the combo, the estrogen progesterone together, I try to limit that to about no more than 5 years. With estrogen alone, you can do it for up to 10 years. What I don't like to see is women doing hormone replacement like into their 60s, 70s, 80s. Like when you start getting past 10, 15 years of hormone replacement, then we do see breast cancer risks going up with that. So I think at some point, we all have to succumb to natural menopause.
Yeah, I know. Nothing is fun, right? Being a woman, so
Yeah.
many things are, problematic. So, but what are some of the, I can tell you another myth. When you have a menopause, you're in lower risk of getting breast cancer.
Yeah, that's definitely a myth. Two things with that. We are seeing more younger breast cancer now.
Why
And
is that?
well, I don't want to sound like a conspiracy theorist, but I think it's environmental. I can't, I suspect there might be something to do with diet, processed foods, microplastics, and all that, because I am absolutely seeing younger women and they don't have genes like the BRCA gene, which would predispose them to get breast cancer at a young age. I'm just not seeing them having these
How
genes.
young you say when you say younger women?
Perspective, like I've been in practice 14 years. And when I first got out of training, it was kind of shocking to see women in their 40s with breast cancer, and very shocking. Maybe it happened a couple times a year to see women in their 30s with breast cancer. So fast forward 10 years, I see someone every week in their 40s with breast cancer now. I couple times a month in their 30s, and I have 6 patients in their late 20s with breast cancer. Only 2 of them have a gene that explains it, and we're also seeing it with gastrointestinal cancers too. It is skewing younger. Like, we have big databases called the SEER databases, and, like, these numbers are playing out, like, we're seeing it in the statistics. So I think there are environmental factors, and younger women with breast cancer do tend to have more aggressive ones too. So there's that part of it. But to answer your question about when you're in menopause, the risk is lower. Like, yes, your estrogen levels go down and that's helpful. But what's the biggest risk factor for any cancer? It's aging. As we get older, our DNA kind of gets, damaged. We get gray hair, we get wrinkles. Well, it also can happen in our bone marrow, in our breast cancer cells, like, in any cell of the body. The biggest risk factor for cancer is aging because of just random acquired DNA damage that can let a cancer cell grow.
We talk about genes, genetics, and about some environmental and food factors. But who normally gets breast cancer? Men, women? Why do we get breast cancer besides what you just mentioned?
Well, I mean, what is cancer? It's a cell that keeps growing when it should have died. So why does that happen? If you have, like, for example, the BRCA gene, it's a DNA repair gene. It makes like enzymes that repair DNA in the cell, or mechanisms that repair DNA in the cell. So if you have an error in your DNA repair mechanisms, you can see how these cells will get screwed up. There's something called a tumor suppressor gene, and that basically it does exactly what you would think. It kind of suppresses those mechanisms of cells that will keep a cell from not dying when it should. So it kind of like all cells should die at a certain point, and if they don't die and they keep growing, a lot of tumor suppressor genes moderate that. Or there's something called an oncogene, where if that gets turned on, it kind of pressures the cell to grow. So those are, like, on a molecular level, the reason that cells keep growing and make cancer. So that applies not just to breast cells. It applies to bone marrow cells. It applies to colon, mucosa cells. So that's how cancer happens. So if you're born with a gene that kind of puts you at risk for it, that's one thing. Or if you have an environmental factor like, Agent Orange exposure, um, that just wrecks your DNA. I mean, I have veterans who have 2 different lymphomas and a blood cancer. Like, that doesn't happen in nature. That was Agent Orange exposure. So it can be environmental, or it's the genes you're born with, and then the environmental exposures that subsequently happen that just deregulate a cell for it to keep growing and, you know, spread through the body, causing various anatomic problems.
Yeah, and as human beings, you're right, we're limited human beings. What can we do? Is there anything we can do to avoid it or to reduce the chance?
Ugh. Theoretically, yes. For now, we have an environmental protection agency. So there are government regulations to shut down Superfund sites and regulate pollution. Don't, one thing you can do is don't use Roundup. It is a carcinogen, it causes blood cancers. There's class action lawsuits. So, like, I forbid any type of pesticide on my grass, or anywhere at my house. I have well water. Like, why would you spray cancer causing agents into the ground from which you get your water?
Wow, so that's important, an important one.
Yeah. Yeah, but I mean, we get our food from all over the world. You don't know what's on it. And I even question some of those organic stickers and what people really have to do to get those. Like, what are really the regulations? So, other things that you can do to prevent cancer, of course, use sunscreen. And I also highly recommend to parents to have their children get vaccinated for the human papillomavirus, HPV. That is an oncovirus that can cause mutations in cervical cancer, or cervical cells, like cells around the anus, in the head and neck. So that virus actually causes cancer. So if you vaccinate your child before they become sexually active, because it's a sexually transmitted virus, if everybody did that, we could almost completely eradicate those diseases.
What age are we talking about? Because you never, sometimes you don't know when your child is going to be
I
sexually
mean,
active, right?
I'd say 9 or 10, or listen to your I'm not a pediatrician. Listen to your pediatrician, and I can't think of a more uncomfortable thing to talk to your pediatrician about than when is my child going to become sexually active. But I think, you know, it doesn't have to be right before they become sexually active. So if you do it around 9 or 10, they're vaccinated.
And it's a
And it
one-time
really
vaccine.
You know what? I'm actually not sure if it's one dose, if it's more than one dose. I'm not sure because this is more pediatrics, and I deal in adults.
What are
Yeah.
some of the concerns of parents, also you're not a pediatrician, about not doing it? Are there any cons to the vaccine?
I mean, when you get a vaccine, sometimes you can feel a little crappy as your immune system mounts, the response to it. It's why we feel crappy after our flu shots and our COVID shots and all that stuff too. But honestly, off the top of my head, I don't know of any significant adverse reactions. There's a lot of misinformation online. I just think like a lot of anticipation of adverse reactions. All of my friends who have had children of those ages have gotten their kids vaccinated, and I really haven't heard of much. But like I said, it's not something I give for a living. I kind of deal with things when cancer's already happened. So, but I would, highly recommend it. And, talk to your pediatrician and make sure your child specifically doesn't have any contraindications because they're going to be a little more versed in this.
Prevention. How could you prevent? Let's go back to your field of expertise. How do you prevent, besides what you can do or you cannot do environmentally, breast cancer? You're talking about mammograms. Everybody talks about mammograms, but do people actually do them? And who has to do them? Male, women, when you find, how does that work? And what kind of other tests are besides the mammograms?
Most At least the American Cancer Society guidelines recommend starting mammograms at age 40. I think some of the primary care guidelines are a little bit different, but I go with American Cancer Society guidelines and I say start at 40 and do it every year. At some point, they may lower it, but they haven't yet. They lower the age. Now, if you have a first degree family member who had breast cancer, let's say at the age of 40, let's say your mother had breast cancer at 40, there's not a lot of data to support it, but kind of arbitrarily, we say start your breast cancer screening 10 years earlier. Where it gets difficult is mammograms are not very accurate under the age of 30 because breast tissue is just too dense. It really affects the sensitivity of a mammogram. Another way to screen, especially in people who have dense breasts, is breast MRI. And that's a very sensitive test. It's a little bigger deal. You have to lay face down. You're in that tube. People get claustrophobic. It can be expensive too. It's a more expensive test. If you have very dense breasts, if you have higher risks based on your family history, or if you have genetics that make your risks higher, we'll even alternate in mammogram and MRI alternating every 6 months. So that's another way to enhance your screening. Breast ultrasound, it's not a super sensitive test. Like it's good for picking up a cyst because you can see like fluid filled things better with an ultrasound. But, the point of catching things early is catching them when they're so tiny that they may even be beyond the sensitivity of an ultrasound. So really, mammograms and MRIs are your mainstay. There is something called a contrast enhanced mammogram, where they actually give you some contrast to look where blood flow is going. And same thing on MRIs. Like when you use the contrast on the MRIs, you can see where blood flow goes. And if you see areas of what we call enhancement, you might not see a mass there, but if you see a bunch of blood supply going to a certain area, you may say to yourself, what is that there, and decide to biopsy that area. There's other things out there, like I think there is a PET scanner. PET is a specific type of glucose tagged nuclear contrast, which we use for the full body because anything growing will use glucose as its energy to grow, and you can measure it that way. But it's not really, breast PET is not really standard of care. Insurance companies certainly are not paying for it. I never do it for breast specifically. And then there are some all other modalities that you may read about on the internet, not really FDA approved, not standard of care in medicine.
So which one would you say by default if you have to do no matter what? The
I would
mammo
say,
says
mammogram. And my only caveat to mammogram really is if they kind of make you in the category of extremely dense breasts, sometimes it's like trying to pick out something in a snowstorm. It just really lowers the sensitivity of a mammogram, and that's where it's reasonable to alternate in breast MRI.
Some people say, I want to do something else, something more holistic. It hurts when I do it. Is there an alternative?
So my incredibly unempathetic answer is, you know what hurts more than a mammogram? Stage 4 breast cancer in your bone. So go get your mammogram.
Yeah, and don't complain.
But in all fairness, there are some people who cannot physically do a mammogram. Like you have to be able to stand most of the time, and it does hurt. So if someone truly cannot tolerate it, you can do breast MRI like you're laying for that, but you're laying prone and there's like this divider between your breast, and that's very uncomfortable and people get claustrophobic. You can also do an ultrasound. An ultrasound is probably the most physically easy thing to tolerate, but it is not as sensitive as a mammogram.
So mammograms. So don't you know that there's some cultures that the women don't want to talk about GI issues or their sexual organs, and they
Mhm.
just kind of like deny that they have to do it. Like you don't go
Mhm.
and get vaccinated or you don't go for your checkup once a year, right? So they push it away. I had an older woman friend that she had she never went to do a mammogram because she didn't believe in them, and then once she just found something, felt something, and she took her like 4 or 5 months to go,
Mhm.
and she didn't believe in insurance because insurance wouldn't pay for it. She was so mad, and I finally found a way to for her to do it, and she did all the treatments, and she's alive today. But it took her a few
Mhm.
months, and during those months, it grew, obviously, right? So
Mhm.
what are you testing? What would you say to these women? Oh, I don't have insurance. Oh no, it won't happen to me. Like, yeah,
Right. It's just like you can't have COVID if you don't test for it, right?
right, yeah, exactly.
So I sent you a link in the chat in terms of access to mammograms. We can put it in the chat. If you do not have insurance or you're underinsured or low income, Pennsylvania specifically has a program in the state where you can get free mammograms and free pap smears.
Free means really free, or is
Free
it
means really
just
free. Free's free.
okay? What
Yeah, I mean,
I
usually it's, a lot of times, like, it's in resident clinics and stuff, like, at, teaching centers, but yes, in Pennsylvania, I know for sure, like, this program exists, I put the link in, and, it's gonna vary from state to state. I do not know of any federal programs, so in your specific state, I found the link, I Googled free mammogram program in my state for uninsured women, and I've just found the link right away. These things do exist, and in reality a mammogram probably costs $100, and that's a whole lot cheaper than treating a stage 4 cancer, so it is in the best interest of the state to try to catch this stuff early.
what happens with these people who have free mammograms if they get diagnosed?
As of now, in the state of Pennsylvania, there is a specific Medicaid plan for patients with breast cancer and GYN cancers, so like cervical, ovarian, whatnot. Because I have had patients who even had health insurance, they were working, they got a stage 4 breast cancer diagnosis and lost their jobs and insurance as a result of it. Like it's seamless. I call my social worker, they sign them up for the specific Medicaid plan, and that coverage is great. So like let's say you are completely uninsured, which may be looming in the future,
Yeah,
seeing what happens with the Affordable Care Act. Let's say you're uninsured and you have an abnormal mammogram. Most big hospital systems have like a breast health services where then they kind of shunt you right into getting a biopsy. You may get some bills as a result of that. You don't pay them. You talk, there's a lot of like social work support, especially associated with breast cancer. And then they can start working on getting you enrolled in a Medicaid program. Because, the reality is the hospital wants to get paid. It's in their best interest to get you insured. So, like, the nice, quote unquote, nice thing about breast cancer is that there are a lot of ancillary services and support. And, the pink ribbon advocacy groups, they are strong and have been very successful. So, take the first step, get your mammogram. And if we do find something, there's a lot of support, especially with this disease.
support. Okay, we're going to take a break because this is a very long conversation. We want to do it in depth. So this is part one now, and then we'll go to part two. Part two will be like, oh, Now you are diagnosed. What
Mhm.
happens then? Okay, so let's
Okay.
take a break, coffee break. Thank you, Nicole. And in a minute, we'll be in part 2.